Good afternoon, everyone, and thank you very much, Dr. Krishnavani ma'am, and to the Obstetric and Gynae Department at Yashoda High-Tech for this wonderful conference, the day seminar that has been arranged today. So I think we are standing between the lunch and you guys, so we'll try to speed up as much as possible. So without further ado, the main contents of what I'm going to talk about is liver diseases in pregnancy. There are certain diseases which are common in pregnancy, but of course there are also diseases which are unique to pregnancy, which are very, very much unique, as I mentioned in the top here, particularly the intrahepatic cholestasis of pregnancy, hyperemesis gravidarum, HELLP syndrome, preeclampsia, and acute fatty liver pregnancy. So we're going to touch more about these kind of diseases, and of course we also will talk about certain diseases which are common in cirrhotic patients. If they become pregnant, how are we actually going to manage those complications? And also unrelated to the pregnancy, if they have any background liver diseases, how are we going to manage them? So I'm sorry for these busy slides, but essentially what I'm going to try here is what happens in a normal pregnancy is you have increased bile composition, particularly increase in cholesterol supersaturation. You have increased risk of gallstone formation because of increased stasis in the gallbladder. You also have, particularly in the second and third trimester, you have an increased blood volume, which increases the stress on the liver, and also there are certain hemodilution that happens, and also coagulation disorders, which we already discussed earlier. So things which don't get changed, which you need to understand, is bilirubin, transaminases, prothrombin. They will not change in a normal pregnancy, in a normal status of pregnancy. Things which would change is the alkaline phosphatase, which can go up to 4-fold because of the production from the placenta itself. Bile acids can increase in fold, which we'll discuss particularly in IHCP, the intrahepatic cholestasis. Fibrinogen consumption also increased by 50%. So these are predominantly the things which we see, but if you have any patients with any raise in bilirubin, alkaline the transaminases and prothrombin, definitely that needs to be considered as abnormal. Okay, so I think this slide sums up in terms of the timing of the problems which are of the disease which are seen in pregnancy. If you see hyperemesis gravidarum, which we normally see in the first trimester, if you have intrahepatic cholestasis pregnancy, we see generally in the second and third trimester. HELLP syndrome, which we normally see in the second and third, and also preeclampsia, and so is the acute fatty liver pregnancy in the third trimester. So I think timing of these diseases help us to differentiate in terms of trimester-wise, to differentiate between the different diseases. So coming to the hyperemesis gravidarum, generally they present with vomiting, as you know, and generally the people who are actually having hyperthyroidism, psychiatric illness, molar pregnancies, pre-existing diabetes, multiple pregnancies, high HCG levels, they are at increased risk of developing the hyperemesis gravidarum. And essentially what you see is up to transaminases elevated up to 400 to 1000 ALT level elevation with occasional jaundice we see, and also more important dyslipidemia because of vomiting and the acute kidney injury that we see. Generally these are very safe as long as you manage the symptoms, they do settle down by themselves. Effects on fetus are not very clear. Some fetuses are known to have undescended testes, hip dysplasia, Down syndrome have been reported, but these are very rare. Treatment essentially is rehydration and nutritional support, and feeding, as we discussed. So in terms of safe drugs, you can use promethazine, metoclopramide, and ondansetron. These are pretty much safe drugs, so you can use as an antiemetic in the hyperemesis gravidarum. So coming to IHCP, which is more common. In fact, the most common unique pregnancy disease in pregnancy that we see is IHCP, and generally they present with pruritus. Generally we see that in second and third trimester, and we see with the mild jaundice up to 5 milligrams per deciliter. Sometimes pruritus precedes the abnormal LFTs as well, and the good thing is cholestasis disappears after delivery. Of course, once they have a IHCP or cholestasis of pregnancy, the risk of recurrence rate is very high for these patients. Despite delivery, if the cholestasis does not disappear, then we have to start suspecting other conditions, liver intrinsic pathologies like the PBC, primary biliary cholangitis, or the PSC. So in terms of lab findings, I think the important thing we need to understand here is the bile acids. If you have a high fasting bile acids, if they're more than 100-fold, they have increased risk of mortality to the baby, to the fetus. So as I written down here, fetal and perinatal mortality is up to 1.4%, especially if you have high bile acid levels. generally have raised ALT and AST, which up to 1000, as I said earlier, and also slight bilirubinemia with slight raise in alkaline phosphatase, but generally GGT remains normal or marginally high. If you have a patient with high alkaline phosphatase and GGT which is high, then you should always suspect other conditions like the like obstruction, biliary obstruction like stones or cholangitis or cholelocholithiasis. We generally don't have to do liver biopsy to prove this disease, as long as we excluded other intrinsic deadly diseases like the HELLP syndrome and the AFLP. If the prothrombin is normal, there is no hypoglycemia, then you can just reassure these patients and then treat these patients with a conservative management. So etiology is unknown, but there are certain genetic predispositions, particularly in Scandinavian countries we see, and also it is commonly seen even in Scandinavian countries, more in the winter states, we see more of these IHCP. Possibility of metabolic and also mutations, particularly people with this condition called PFIC, they have increased risk of developing IHCP is been noted. So the risk with the fetus is that because it causes vasospasm, the bile acids are can cause vasospasm to the placental vessels and causing asphyxia and the mortality. Treatment is quite simple. Ursodeoxycholic acid is generally being preferred. Most of the people settle with ursodeoxycholic acid, and sometimes we have to use cholestyramine to reduce the load of the bile acids, and sometimes we also use SAMI, which is the which helps in mopping up the bile acids, and also sometimes ultraviolet light also helps. So in terms of monitoring to the fetus, close monitoring of the placental insufficiency of the fetus is very important. Delivery of the baby as soon as they mature is what is recommended. So if they are about 34 weeks stable, then we generally advise them to recommend to go for the delivery for these babies.